Hi, everyone. So glad to have you here for this opportunity, this training opportunity. And thank you, Peter, and your team for being here and putting this on for us. We truly appreciate it.
Absolutely. I hope everybody had something to eat. Otherwise, you might get cranky halfway through. Let's see how we're doing here. We're just going to start in 1 minute, and then others will just have to join whenever they show up. Okay. First of all, I just would like to welcome everybody. This is a webinar on pandemic mental health for religious leaders, sponsored by Faith in Action in Fairfax County, where you're all based. And with me from the NYDIS staff is Gabrielle Sclafani, who is our manager of our Faith Sector Community Preparedness Program, and Susan Polewski, who works on our COVID-19 outreach and education program with the New York City Department of Health and the Fund for Public Health in New York. So this is a course based on a toolkit that was developed by Thrive NYC, which is a mental health initiative to build mental health resilience in communities. But obviously the content is applicable to any community and any faith leader. So I'm assuming everyone is a Zoom expert by now, considering it's been almost 12 months since we've been Zooming. If you're not familiar, you can certainly type a question in the chat, and Susan or Gabrielle can try to answer it for you. But in general, the only buttons you need to know about are mute. So please keep yourself muted unless you're asking a question. And also feel free to type any questions you have into the chat box if you don't want to ask the question out loud. You can also raise your hand. That's another option. And that'll put a little hand icon on your screen, and somebody will call on you at the appropriate time. But we want it to be interactive, so please feel free to speak up whenever you have a question. My name is Peter Gudaitis. I'm the Executive Director of New York Disaster Interfaith Services, and I happen to serve as the president of the National Disaster Interfaith Network. I've been down to Fairfax a number of times to train disaster spiritual caregivers there, along with two of my other colleagues, the Reverend Ruth Yoder Wenger and the Reverend Fred Mead. And we've certainly appreciated that long relationship. I've already introduced Gabrielle and Susan, and I just think to get us started, it would be helpful to hear from each of you. I don't know if you all know each other, about your name, your title, your congregation, perhaps your affiliation with Faith Communities in Action. And because everybody's face is on the screen in different orders on different screens, I'm just going to call folks out. And we're going to start with John Conway.
Good evening, and thank you for having this, Peter. As I said, I'm John Conway. I'm an ordained minister in the Methodist Church, and I work for, among other things, what we call our district, or Arlington District, which includes Fairfax County. So we have a lot of Methodist churches in Fairfax County, so that's why I'm here, but also to pass on what I learned here to our clergy in Arlington and Fairfax County and Loudoun County. We go out that far. So thank you, Peter and all for doing this.
Absolutely. Jerry Foltz.
Good evening. I'm Jerry Foltz. I'm a retired pastor in the United Church of Christ, and I've been over 20 years with a volunteer fire chaplain with the Fairfax County Fire and Rescue Department.
Thank you. And Jerry Fields.
Hi, Peter. It's good to see you again.
You too.
I'm Jerry Fields, and I am PCUSA Presbyterian pastor. I am also a chaplain for Fairfax County Police Department and a member of the leadership team for the community chaplains that we have. And so I'm excited to be here and to see what all you have to share with us today. So thank you, Peter.
Thank you. Noah? Can you find your mute button? We'll give you a minute and come back to you. Caroline?
Hello, my name's Caroline Rankin. I work with Fairfax County Neighborhood and Community Services, and I'm one of the support staff for the Faith Communities in Action and the Community Chaplain Corps.
Okay, thanks. Noah, did you find your mute button yet? Nope. Okay. Jenny?
Yes, sorry, I was a few minutes late. Yes, I'm a chaplain and a visitation pastor in the United Church of Christ, and I'm part of the disaster response team for the Penn Southeast Conference here in Pennsylvania. And we have a Keystone Disaster Spiritual Care Network, a hotline that I'm part of.
Great, thank you. Back to you, Noah.
Yeah, this is Noah. I'm a Korean pastor leading a small Korean church here. And then the day before yesterday, I received an email from Pastor Daniel Park, and then I registered. Oh, I'm not that much experienced, and then I don't assume that much responsibility, but I'm interested in this part. And please excuse me that from 8 o'clock I have another meeting, so I'll leave that time. Thank you. Nice to see you guys.
Thank you. Mohammed.
Yes, please. My name is Mohammed. Last name is Abdulillah. I'm the religious leader for the Moroccan Muslim American community, and here in Northern Virginia and Fairfax, I'm part of the Interfaith of the chaplains. Which Ramona, leads and help us get to learn more and understand how to deal with issues as it arises. Thank you.
Thank you.
Happy to be here.
Tom?
Tom Joyce. I serve as a pastor at Emmanuel Bible Church in Springfield, and I am a Fairfax County Police Chaplain working out of West Springfield.
Thank you. And Joyce? Tom Joyce.
You want Tom Joyce or Joyce Howard?
Oh, Joyce Howard. Yes, you first.
Okay. I'm Joyce Howard. I'm part of the clergy with Heritage Fellowship Church. And I'm also part of the clergy with a new organization called Christians United Against Systemic Injustice. So I'm interested in seeing what I can learn here and take back to the areas in where I work.
Thank you. Tom Joyce this time?
You already heard from me, Peter.
Oh, you already heard from me. Oh, sorry. Sant's iPhone. All right, we'll come back to Sant's iPhone. Anne? Sensible?
Can you hear me now?
Oh, yep, we can hear you.
Okay, so my name is Sant Gupta. I'm associated with Durga Temple of Virginia in Fairfax Station, and my responsibility is outreach and interfaith dialogue. I have been the president of the temple, and I participate in things that help me learn about other faiths, and I carry the message to my community. Thank you.
Thank you. So Anne Sensible, I think you're the last one.
Hi, I'm Ann Sensible. I'm just a member of Burke United Methodist, and I'm a nurse, and we're trying to bring a mental health awareness and to our church.
Okay, thank you.
Thank you.
Anybody who comes after this, they miss their opportunity. Okay, so hopefully this will be a relatively relaxed conversation and not a formal one, so feel free to step in whenever you'd like. It's facilitated discussion along with presentation, but it's pretty densely packed. So if you need to raise your hand or interrupt me, go ahead and do that. Everyone's context and relationship with the pandemic is different. And I just want to name that up front. On our last webinar, we had a clergy person who'd recently lost her husband to COVID, and others that had it, others that had lost family members. So we all have a very different relationship to the pandemic. And group participation is, of course, encouraged. Okay, so let's look at our objectives overall. We want to help you figure out how to best serve your community of faith and the people that congregation or organization serves out there in the community. So not just devotees or members. We want to help those that are struggling with all of the stressors of the pandemic cope in a healthy way with everything they've experienced. And I think it's important for us to name up front the pandemic is far from over. There are many more months of vaccine rollout. Just about 30% of the US population is vaccine averse. And that is another challenge that we have to face as a country. We want to get to somewhere between 70 and 80% herd immunity in the United States. Given the fact that about 24–25% of our population is under 18, that would require every single adult to be vaccinated. And given the fact that that's not likely because of the anti-vaxxer movement and those that aren't quite ready to trust the vaccine yet, we do have a significant time to go before we achieve general herd immunity. We want to restore the balance between physical, mental, spiritual, and emotional well-being. Some people have lost weight because of COVID. Some people have packed it on. Raise my hand. So I want to make sure that we name the reality that we're all struggling with finding that balance. Some of us are better at it than others, and we need to continue to encourage that. We also need to look very seriously about how we identify and mitigate the effects of stress caused by the reality of COVID-19, and I would throw grief into that as well. Prolonged grief is complicated grief. If you had a loved one who died in June and you thought you would just wait a few months and you'd finally be able to have a funeral and you still can't have one, those emotions are weighing heavily on people and continue to do that. Families with loved ones who die alone because they can't get to their loved ones in medical facilities, not being able to visit distant relatives. My brother has now postponed his wedding 3 times in the last 12 months. I think his wife to be and he are very, very stressed out about that because they want to get married before they start having children and that sort of thing. So just the reality of everything being put on hold and the uncertainty of when that will stop. Providing a pathway for us to identify and refer individuals to professional mental health providers when indicated is also a challenge, not only because it's normally a challenge finding effective mental health providers, because it is, but because mental health is currently often provided virtually, and that's not how most people choose to interact with a mental health provider. They prefer face-to-face interaction as a way of establishing trust. And also we want to talk about the kind of resources that you can access currently for mental health referrals. So the toolkit itself talks about how the information can be made accessible to faith leaders and community leaders, but the content in this version is specifically oriented towards faith leaders. And when I say faith leaders, I mean that in the broadest sense of the word. Those who are ordained, those who are lay people in caregiving roles, those who are doing youth ministry, those who are in leadership in congregations and faith-based nonprofits. So vestries, councils, and those sorts of bodies as well. So what is mental health? What do we mean when we say mental health, and why does it matter for faith leaders in particular? How to support mental health during the crisis and why that's unique. How to support mental health year-round, in other words, emotional resilience. Some biography information and then some additional resources that we'll review as well. These are some other topics mentioned in the toolkit that we're probably not going to dig into too deeply, but there's a whole glossary of terms and definitions around mental wellness and mental illness, moral injury, which I'm sure for those of you who are ordained are familiar with as a term, grief, complicated grief, funerals, self-care, something all clergy are very good at, and how to support mental health year-round, and a mental health action calendar, which we're not going to review. So this is a slide from left over from the 9/11 recovery efforts here in New York City, and it's up for 2 reasons. One, I want to just give 2 different examples. One is a woman who was a member of a congregation here in New York City. She was a huge extrovert, kind of a parish matriarch, very dynamic, was involved in everything, also had a full-time job, and she was widowed, and she witnessed the World Trade Center attacks, and simply watching the attacks that day, not knowing anybody who died, not being involved in the response, but simply being an observer of the attacks, she developed severe post-traumatic stress disorder to the point where she couldn't even take care of herself, lost her job, stopped going to church, and her daughter, her adult daughter, was the sort of wake-up call for her to try to seek help. And yet during that time, she had a lot of support. Her church started paying her rent when she lost her job. So in general, the fabric of her life was held together by others, but she needed to pursue mental health care. The other involves this image, a man walked into Pier 94, which was the Family Assistance Center, and he was the father of a young boy. He was the primary caregiver, the custodial parent, and he showed up there to speak to a chaplain because his young son, 9 years old, had told him that he had to get out of bed and get help because he'd been in bed for almost 2 weeks after narrowly escaping being killed in the World Trade Center. So this is simply to say that sometimes it takes others, family, loved ones, friends, pastors, imams, priests, to identify when something is wrong with an individual who has been coping with or not coping well with the stressors of some sort of traumatic incident. And COVID has become a traumatic incident for countless millions of Americans. As we saw this week, as we hit 500,000 fatalities in the United States alone, and of course millions around the world. 30 million Americans have now had COVID, and just about 30% of people that got COVID here in the United States developed some sort of secondary health condition related to their infection. Cardiac problems, kidney problems, lung problems, and just because you had it and survived doesn't mean it didn't have a crippling impact on your life. And then there's the economic side of the disaster, which I'm sure you're all familiar with as well. Tens of millions of Americans have lost their jobs because businesses have collapsed as a result of the pandemic. So pre-pandemic, pre-COVID, so that would take us back to just about a year ago. So if you rewind your mental timeline, it was just about mid-February when we began talking intensely about the unfolding pandemic and what impact it would have on the United States. And it was in mid-March that many cities and states began to go on some version of a lockdown. The federal travel restrictions started in February. So among Americans, somewhere between 16 and 20% of Americans experience some sort of diagnosable mental illness during any given year. And just to put that in context, right, that's about 80 million people. That doesn't mean that they required hospitalization or medication or necessarily, or not even necessarily mental health treatment, but they had a diagnosable condition. So those things already pre-existed COVID. Chronic mental illness would look like depression or schizophrenia or other diagnosable disorders, but it could also be substance use or abuse. It could be eating disorders, seasonal affective disorder. We have profound mental health inequities in the United States based on poverty, race, immigration status, sexual orientation, sexual identity, gender identity. It just depends on where we live and how accessible the services we need are, and whether or not we are insured to access those services or personally have the resources or know people that have the resources to help us. We have a long legacy of discrimination and racial discrimination, racial violence, xenophobia. If you look at the number of mental health practitioners in the United States that are people of color or from minority faith communities, for instance, like Muslims or Sikhs or Buddhists. There is also a lack of licensed providers, sometimes from the communities we come from, that we would feel best served by. And socioeconomic disparities, of course, are tremendous. Now add COVID to all of that. So if you were already poor and already uninsured, how much harder has it been for the past 10 months? In New York City, I'll give you an example. It's estimated that 60,000 students under the age of 18 didn't have a computer, even though we were on mandatory remote school. So that's in a city with about 1 million school-age children. So that disparity would exist in all communities amongst the poor. Increased stress because of the pandemic, economic stress, stress on health. And we also have to talk about the implications of recommended safety procedures. If any of you are on Facebook, you will appreciate the fact that there is not consensus on mask wearing, right? Oddly enough, Americans don't all agree on something. Social media is, in general, I hope we can all agree, not a good place to get medical advice. Let's trust our public health experts more than self-appointed experts on social media. But there's been a decrease in access to care. I had COVID in March of 2020. When I had it in March, you couldn't get a doctor's appointment because all the doctors were only seeing people remotely. You also couldn't get tested because there weren't enough tests. So I was only able to determine that I had had COVID in May because that was the soonest I could go to my doctor and get tested for antibodies, which proved I had had COVID. And this is, of course, ongoing. People have challenges getting even tested in some communities. Multiple losses. Most, if not all of us, have known people that have died from COVID in our families, in our congregations, in our communities. We certainly know famous people that have died or become ill. The President of the United States became ill, even with all the protections around him. Former president, sorry. Multiple losses also includes the loss of intimacy, the loss of social life, the loss of congregational community, of corporate worship. All of those things have a negative impact on our wellness. And early altruism and heroic responses give way to disillusionment. How many of us have been assuming since a year ago that in just a couple months things will be better? Now it's been a year and the vaccine's here. I think that there's definitely hope in that. But when it takes you 12 to 18 to 20 weeks to get a vaccine appointment, it doesn't feel that convenient. So normally in a disaster, we look at two different life cycles: mitigation, preparedness, response, and recovery. And then on the right-hand side of your screen, you're going to see the emotional impact. So this is a disaster life cycle, and then the emotional impact. Currently, depending on who we are and what our experience of the pandemic is, we're not quite sure where we fit in that life cycle. Some of us are still preventing, right? We're in mitigation phase, trying to make sure we don't get it, but we still have our jobs, we're still healthy. Others are preparing, constantly preparing, reassessing, evaluating the readiness of the institutions that we serve, the congregations that we serve. Others of us are responding. We're feeding people. We're chaplains in hospitals and schools. We're constantly interacting as a caregiver. And other families have been through it. They lost their spouse. They've survived. They're trying to figure out how to rebuild their life. So we're not all in the same place in that life cycle. If you look to the right, you see this image of kind of our emotional reaction, kind of looking like a heartbeat. Pre-disaster, we know things could be bad, but we're never sure. Everybody's usually optimistic. Most people suffer from not me when they're faced with a threat. It's going to happen to somebody else. And others of us are very paranoid to the point of obsessive about it. 2 pairs of gloves, 2 masks, face shield, wash your hands 27 times a day. It just depends on who we are and what our own way of coping with stress looks like. We're in the impact phase, and we've been in the impact phase of the pandemic for a year. That hypervigilance, particularly in those that have a tendency towards obsessive compulsive behavior, has a very profound cumulative effect on us emotionally. We also have oftentimes we've experienced sort of periods of heroic adulation. Dr. Fauci is a hero to some people and a demon to others. People see hope in announcements like the pandemic is now seeing fatality rates drop, infection rates are dropping, hospitalization rates are dropping, vaccine rates are going up. And then you hit an anniversary or an event like 500,000 fatalities, and that's a little bit of a trigger event for us. It's another reality check that despite the fact that things are looking good, there's still an awful lot of people dying, still somewhere between 1,500 and 1,800 Americans a day. And we were up towards over 3,000 a few weeks ago. These are horrible numbers, disturbing numbers, hard to get your head around numbers. The other reality is during this past year, we've had other stressors in our lives. Was our presidential election stress-free? Not for me. I'll speak for myself. I thought it was very stressful. We also experienced a reawakening in a very dynamic way, the fight for racial equity and equality in the United States. The death of George Floyd last spring sparked, reignited, I think, the fight for racial justice and equity, spearheaded by the Black Lives Matter movement, protests around the country, sometimes violent protests, and a re-examining of white supremacy and white nationalism. And all of these things were hitting during the pandemic. So all of this is making things more complicated. It's just more layers of complexity to how people are coping with all the challenges they're facing in their life. So today we're going to talk about these 5 topics in particular: how stress affects us, how trauma affects us, and those being 2 distinctly different things, grief, self-care, and the referral process. So we're going to do a poll right now that I want you to participate in. On a scale of 1 to 5, how stressed are you feeling today, right now? And you might be feeling more stressed after hearing what I have to say than you were when you got on the call, but that's okay. But just share how stressed you're personally feeling today. This is anonymous. We cannot see who answers what questions, even on the back end. 33% of you are very chill right now. You're home, maybe you had a bite to eat, you're listening, not feeling stressed out, but an equal third are slightly stressed, probably because of the conversation. 22% feeling moderately stressed and 11% rather stressed. We had some highly stressed on the last course. So part of that just depends on how our day went, right? Not necessarily the cumulative effects of what's going on. Oop. So by stress, this is what we're talking about. Feeling anxious, lonely, or sad are common reactions to conditions of physical distancing, isolation, and quarantine. So stress is normal faced with anxiety, loneliness, sadness, social distancing, isolation, quarantine, right? Those are stressful environments. For any of you that have school-age children or grandchildren that you're taking care of, remote learning is stressful. For the learner and the person responsible for the accountability of whoever's sitting in front of that computer all day long. We have to be able to name that those things are stressful. Suicidality amongst young people is up dramatically because of remote learning. Disengaging children from their social networks is stressful and traumatic to children. And it has increased not only suicidality, so thoughts of suicide, but also those who are attempting or completing suicide. Acute stress. These are symptoms of stress that last for a significant period of time. In general, 2 or more weeks. If someone is feeling signs or symptoms of stress for 2 or more weeks, that is a sign of significant stress or acute stress. And I think we can all agree that for some of us, not necessarily those of us on the call, but people we know, families, loved ones, they have been feeling significant stress for the better part of a year. Some people lost their jobs last March. I don't know about you, but I couldn't survive a year without income very easily. It would be incredibly stressful. Symptoms of stress are magnified for someone who is experiencing acute stress. So they're not just feeling anxiety in a typical manner, they're feeling hypervigilant anxiety. Symptoms of stress begin to affect a person's with acute stress, their ability to care for themselves or be in relationship to others. Now, some of that's a little tongue-in-cheek. You can go to Zoom meetings with your pajama bottoms on, right? That's not necessarily not taking care of yourself. But if you've got your pajama bottoms on and you've had your pajama bottoms on for all your Zoom meetings for 2 weeks, and you're showering every 4th or 5th day, that's not normal. It might be for a few people, but in general, that's not normal. And this is where it becomes a challenge for us as caregivers. Normally, in a pastoral role, we interact with people in person. We do home visits, we see them at worship, we see them at congregational events, we see them out in public. Under quarantine, we're not necessarily interacting with people that way. I can't experience what your house looks like, what you smell like, how you look, how disheveled you are. That's all somewhat hidden by remotely interacting with people. So it's harder for us to identify when someone's experiencing acute stress unless they're willing to share how they're feeling with us. It's also hard for anyone going through acute stress sometimes to recognize that these are the challenges facing them. They can't name it. Signs of traumatic stress. Okay, this is different than normal stress. Panic comes with panic disorder, constant hypervigilance. You don't need to have your face mask on when you're outside doing yard work. You don't need to have your face mask on when you're driving in your car alone. You don't need to have your face mask on at home with family that you live with. You don't have to wear gloves in your own house, but there are people doing that. And that's taking protective measures to an extreme. That level of hypervigilance means that you are traumatized by the stress that you're under. Re-experiencing traumatic events. So, this isn't really a good time to watch the movie Contagion. But if you go on Netflix, it's one of the recommended movies. So that means lots of people are watching it right now. Flashbacks to other previous stressful events, or perhaps flashback to losing other loved ones because you've recently lost loved ones to this pandemic. Losing touch with your surroundings and memories. I don't remember where I've left things, and I've forgotten what Christmas was like, and I don't remember when the last time the family got together. Kind of losing touch with ritual and things that ground us. Difficulty sleeping or concentrating, and again, we're not talking about periodic difficulty sleeping or concentrating. We're talking about constant challenges with difficulty sleeping or concentrating. Feeling more irritable than usual. Some of us are grumpy all the time. Ask your kids if you're not sure if that's you. Some of us are constantly grumpy. We're looking for a change, right? If you're normally grumpy and you're still grumpy, that's not a change. If you're normally bubbly and a huge extrovert and smiling about everything, and now you're grumpy, that's concerning. Becoming withdrawn and avoiding reminders of the experience. You can't avoid going out of your house during a pandemic for essential things. Most of us still have to go to the bank. We have to go shopping. You have to see the doctor. But if we are literally locking ourselves up, not doing any of those things, maybe there's good reasons. Maybe someone has cancer or HIV, and they really are extremely high risk. But for others, doing some of those routine things and using measured preparedness techniques like face masks and hand sanitizer are sufficient. So we're looking for these indicators to determine whether or not someone's been traumatized by the acute stress that they're under. It's important for all of us also as caregivers, and I'm sure you've all heard this in your chaplaincy training, we have to know when we're in over our head as caregivers. Somewhere in between acute stress and traumatic stress is the difference between when pastoral counseling and care ends and the need for mental health care begins. And we need to be aware of our own skills, our own gifts and talents, our own experience and expertise ends, and where we need to refer someone to clinical care. So let's look at risk factors for traumatization, because all of us are trying to eliminate as many of these as possible for our congregations and for our family and ourselves. Proximity to sickness. Can clergy limit that? Not really, right? If we have people that are sick in our congregations, in our mosques, in our temples, we can't limit our proximity to it. That doesn't mean we have to get in the room with the person, but it's always around us. We're always aware of it. Death and other traumatic experiences, right? Life is going on as normal, no matter what the pandemic is doing. People are getting in car accidents. People are having heart attacks. People are losing their jobs. Multiple traumatic experiences. If we know someone in our care or ourselves have had multiple traumatic experiences or a history of trauma, a previous experience with disaster, those things increase our risk factors as well. Medical illness and mental health challenges also are risk factors. Substance use and abuse, food abuse, older people, people who are in group facilities or nursing homes, and ethnic and racial minority groups. In the United States today, you are 3 times more likely to get infected and die from COVID if you are Black. You are 1.5 times more likely to get infected or die of COVID if you are Latino. Risk factors are similar for Caucasian and Asian Americans. They're almost as high for Native Americans as they are for Black Americans. So those disparities are risk factors for trauma as well. Secondary trauma. This is what we are most vulnerable to as caregivers. We're at risk for secondary or vicarious trauma because we are regularly exposed to the high number of fatalities, illnesses, and grief cycles of those whom we care for. And the more we're exposed to the same thing, the more of a cumulative effect it has. Now, all of us in congregation life experience life cycle deaths, right? People die every year. People get cancer, people have heart attacks, car accidents, all sorts of things. But those types of deaths vary throughout the year. If you were in a congregation where in a given year, most people were dying of cancer, that would change the kind of trauma that you're living through. We're also repeatedly hearing the same types of grief expressed by family. I couldn't be with my husband, my wife, my mother, my father, my brother and sister when they died. And hearing over and over again the despair that people experience because they couldn't be present with someone who was sick or someone who was dying because of COVID. So there's 4 tasks of grieving, which of course you're all familiar with: accepting the reality of the loss, processing the pain or the grief of that loss, adjusting to a world without that individual whom you loved, and finding an enduring connection with the deceased while embarking on a new phase of life. So, right, your new normal, if you will. Pandemic grief is different because we're not experiencing it just individually. We're experiencing it as a family and as a community of faith or a community of neighbors and a town. It just depends on our setting. So I gave an example 2 weeks ago of a family here in New York, West African immigrant family, Muslim family. That family has lost 30 members to COVID in the past 12 months. It doesn't really even matter who those individuals are, and they're across multiple generations. But loss at that level is hard to imagine. That's the kind of loss you see when your country is at war. It's not normal loss. And what does it take for a family system to recover from that kind of loss? And that's a nuclear family. There have been stories, I'm sure you've read them in the paper, about congregations here in the United States that have lost 6 people, a dozen people, dozens of people. They've lost their pastors, they've lost their imam, they've lost their rabbi. So multiple losses, and it's not just about death as well. People moving away, people self-isolating, not engaging with the community, not being present, as we've discussed, not being able to be physically with family. My mom is 93. Every day is precious for her, but I can't see her that often. It's too risky. So lots of phone calls, not a lot of visits, especially since we've gone back into winter. It was easier in the summer, we could sit outside in the yard. But now it's too hard. Waiting for human remains. Lots of communities can't get deceased individuals' bodies back to families quick enough because the systems are overwhelmed with fatalities. Funerals increase risk, so they're usually limited in numbers. And a lot of us have a lot of complicated feelings about small funerals. It doesn't seem like the final farewell that most people expected and most families want to give their loved ones. And the anticipated grief that lies ahead, not just what we've experienced. So tips for coping with grief: normal as well as complicated, accepting feelings, talking about loss. Hard to do when you live alone and you have lost your ability to connect with congregation and neighbors in a normal way. You almost have to seek out opportunities to talk about loss rather than the normal process, which is I wish people would stop coming up to me and asking me how I am. Like I don't need 40 inquiries a day in the supermarket about how I'm feeling about my late husband. But now you're disconnected from that intensive amount of questioning because someone really has to seek you out to ask you. Take stock of what's going well in your life. Know what resources are available. Coping with grief is difficult for many of us. Some of us are stoics. Some of us are super macho and don't want to admit we need help. Some of us grieve too much and it's distracting us from the normalcy that others need from us. Focus on the things within your control, right? What can you control about grief? What you can't. You can't control the fact that you couldn't be with your loved ones when they died. Limit or moderate your exposure to media coverage. I wasn't really joking too much about social media. Social media is overwhelming amounts of information. A lot of it is inaccurate. A lot of it is hysterical and political. And a lot of it pretends to be expert when it is not. And if you read the comments on even sound medical advice coming, let's say, on a post from the Centers for Disease Control, half of the posts are from some extreme group that thinks the CDC is, trying to stick trackers in everybody with the vaccine. So even credible news sources, the news feeds just add to our anxiety and make our grief worse. Take a break from news. Be part of the community, advocating in safe ways. Ask for help if you feel overwhelmed, and reminding those you care for to seek out help because you don't see them the way you routinely see them. Sometimes when I'm talking to my mom on the phone, I FaceTime her and I ask her to show me what the room looks like, because I want to see whether or not she's sort of taking care of things, or if the house is getting a little messy, so that we can help her out. Complicated grief. This is unexpected grief, and we have to throw, unfortunately, COVID fatalities into this category. If the last time you saw your loved one was weeks ago, when an ambulance came and took them to the hospital because they were having trouble breathing, and you haven't been able to see them other than the occasional FaceTime with a nurse taking care of that, that kind of distance complicates our grieving process. Just the separation itself brings on grieving. But if the person dies during that process, that is bringing on complicated grief for many families. The death of a child, as you know, some very young people have died from COVID. It's not typical, but it happens. But it feels like it's not supposed to happen. Close or dependent relationships to the deceased person. As you all know from your regular ministries, sometimes one spouse survives the other, and the other was responsible for almost everything. They took care of the money, the bills, they made the decisions, and did all the cooking, whatever it is. Without that person, things become much more complicated. Social isolation, of course, is self-evident. A history of depression, separation anxiety, all those things complicate our grief. Traumatic childhood experiences, and major life stressors, especially looking at COVID, the financial hardships of COVID. Self-care, every clergy person's favorite topic. So why is self-care important in working with traumatized persons? How aware are you of your level of compassion fatigue? What do you do for self-care? What might be some of the barriers to your own self-care? And what kinds of things can you do after dealing with traumatized people? Who can you count on to talk to after having a difficult pastoral conversation? I want you to feel free to unmute or type your comments in the chat, and Gabrielle can read them off. But please feel free to respond to any of these. And I'm sure you're already thinking about some. If you'd like to share, please do that. Everybody's feeling shy tonight. Let's discuss an easier one. So what are barriers to our self-care currently because of COVID?
No access maybe to what you did before.
No access to what you were doing before.
Mm-hmm.
In all that implies. Can you go to the gym? Is the gym safe? Nope, not necessarily. Can you visit your friends or go to a neighborhood bar? Not suggesting that any of you are barflies. Exercise class, prayer group, Bible study. What are some other barriers?
Weather has affected it some. It's affected us. Yeah.
Yep.
Cold. Snow, ice.
I think it's much harder here in the northern states during the winter. We don't get as much sun. We can't go to the beach or the pool. We can't do outside dining. Is Zoom worship an equal substitute for in-person corporate worship? Funny how no clergy think that.
It does open up our worship to people in other areas. It's not limited geography, so that's a little bit on the nice side, plus side.
How many of you think you'll go back to only in-person worship? Will you continue doing Zoom worship for those who need it? Because this used to be something that was only left to sort of televangelists, right? Or big cathedrals.
We'll keep doing it.
But every congregation in the United States today has the option of video worship.
I think it will probably need to be a hybrid approach where we have access both ways.
Right. Still can't get communion that way. Laying on of hands, those kinds of things don't work quite the same.
But we are actively pursuing post-COVID to have our worship both online and in person, and also encouraging our people to go to other worship services, to do so online. And it's particularly important for us Methodists, one of the whitest congregations in the country, to expose our white people to Black worship services. And so there's been some silver lining here in getting people familiar with other services. So we're going to continue.
Worship feels more accessible, certainly, I think, and can be last minute sometimes, more accessible to those that are ill, or but I do appreciate the idea that you could visit other types of worship that way, and it would be easier. Okay, let's look at our next poll. So how many days a week on average do you spend practicing self-care? Be honest. Could put up the poll. Less than once a week. Somebody's doctor's not happy with them. Once a week, the same comment. So the rest is pretty evenly split, right? So about 40% doing every day. I admire you, whoever you are. I wish I could say the same. And about 40% of us doing it 2 or 3 days a week. We all need to agree that we need to work towards our brothers and sisters in the everyday realm. And then we also need to be certain that what we define as self-care is actually healthy self-care. Coming home from work every day and having a pint of Haagen-Dazs sounds good in theory. It is not actually defined as good self-care. It's defined as a coping mechanism, but not necessarily good self-care. But I think it's interesting that we are always challenged as caregivers in this area. These are very common answers for those of us in caring professions, including religious leaders. And because we're facing a public health emergency here, it's almost more important than it is in normal times, because keeping ourselves well cared for is also about our physical resilience in the face of the threat of the pandemic. Gaining 30 pounds and sitting on the couch over the past 12 months would make you, put you in a higher risk category for COVID than for someone who's been, walking 3 or 4 miles every day. And some of us are limited by the pandemic, so we're not doing things that we would normally do, like go to the gym or go to the pool or go to Bible study or whatever we do to take care of ourselves. So self-care certainly involves good safety practices. You're throwing a tantrum at the door of Walmart because they won't let you in because you don't have a face mask on. That's not good self-care. It's also not a good look. Caring for our bodies, so trying to eat healthy, trying not to get the COVID belly, to move and stretch. Hard to do when you're sitting in front of Zoom meetings all day long, and I can definitely relate to that. I do a lot of sitting and have been doing a lot of sitting for the last 12 months. Staying connected to loved ones, particularly those that you cannot visit, I definitely have to remind myself to call some of my particularly older relatives who live alone, but also even my younger friends who live alone. I was just having a conversation with a friend of mine who I've known since childhood, who lives here in New York City, is not married, lives alone in an apartment here in the city, and he is feeling very down and out. And he's normally a much more sort of happy-go-lucky person, but he can't travel. He's doesn't get a lot of work. He's an opera singer, and he's having a really hard time. And it's been a year, and it's going to be longer. Here in New York City, the Broadway community announced that they would not open again until 2022. We're only in February. To know that you've got 11 more months of no income, not being with your colleagues at work, not being able to do something you love, definitely is removing your ability to connect with loved ones. And delegate, another thing that's hard to do, especially if you're in a congregation where you're the only ordained caregiver. But are we relying on lay people who have gifts and talents in this area, and are we delegating out as much as we can? Limit your exposure to news about the pandemic. We've talked about that, right? Creative outlets for what you're experiencing. Finding creative ways to get out of the house and creative things to do is still important. Simplify and streamline your tasks. Take time to read, always a good idea. Exercise, probably sitting still isn't one we probably have to recommend right now. Be gentle with yourself, be patient with yourself, even when you feel like you're not doing anything well. I don't hear this as much as I used to, but back in March and April, May, I felt like a lot of my clergy colleagues were very hard on themselves about their crappy online worship. They thought they were technically bad at it. They didn't feel as inspired when preaching as they did when they were face to face with a congregation. And I kind of felt like a lot of my seminary classmates in particular were overly hard on themselves for not being a good TV personality, right? Because that's what you expect of yourself. And most of us don't like seeing ourselves on camera. We're getting used to it, I think, with Zoom. But all of a sudden, when you're leading worship on camera, you think for the first time in your ministry, is that really the way I look? Well, like, is that what I sound like? Do I gesture with my hands that much? I never knew that. Because we're not used to seeing ourselves on camera or recordings of ourselves leading worship. I just see some questions come up. We have a well-known opera singer in our congregation. I can let our guy know about your friend. They could potentially bond. So share in the chat or unmute if you choose to, how you've been practicing self-care. So about 40% of you say you're doing it every day. So what are you doing? What's your go-to thing that helps you feel centered and that you're taking care of yourself?
Well, Mohammed, guys, can you hear me?
Yep.
For me, I'm a Muslim, so I pray 5 times a day, and I think that those times to really connect and understand that there are things out of my hand, you know, and God's going to take care of it. All I can do sometimes is listen, and so emotional support without affecting myself and my family, take that stuff back home. So by praying, it helps me. I mean, going back, seeing my family still around, because I went through Corona and it was very difficult, you know, and it makes you think of appreciate everything than when you go through it more, you know, and when you're going through it, you only think about your family. I didn't think about myself. I just think about my family that to get affected, you know, and by praying and keeping faith, following what the doctor says, you know, thank God I'm still around.
I would agree with that. Thank God you're still around. Spiritual care time in prayer and scripture is offered by John. Jenny mentioned walking, getting exercise, seeing other people around the neighborhood when she's walking, I'm assuming. Gabrielle said it feels more important now than ever, John. Oh, sorry. Yesterday, I discovered a dead end cobblestone street in my neighborhood that I never knew was there. That's interesting, right? We spend more time at home. We discover things we didn't know. Walking your dog. Dogs are great. Dogs and pets in general are great for self-care. They seem to be intuitive sometimes about nuzzling up, right? Prayer and meditation, 2 times per week to go to a workout, walks when weather permits, reading and prayer devotional time. All great suggestions. What policies or practices have you put in place to encourage self-care in your congregation or amongst your staff?
Well, for us as a Muslim, again, we look at it from a different perspective. You have to understand this is a test you're going through. You know, just trust you God. Take, you know, be cautious. Take all the means that is present to you, you know, to protect yourselves and others in the community that you live with. And there is a strong verse in the Quran that says, within hardship there is ease. So always you have to keep thinking positive. There is, you know, you can go through this. So keeping yourself thinking positive, trusting God. And if you need emotional support, just call. We're here to listen, to help. Getting involved, we ask members of the community not to just sit home. Get involved. If you lost your job, try to look for other avenues. Get, you know, read, get some education, get some classes. Think of changing your job. Maybe the job's not exist anymore. So this is some of the things that we talk about, and we try to support each other in this way. And I think
thank you.
It's, you know.
Thank you. Any others?
This is Jerry Fields. One of the things that we did early on and continued, at least while I was at that church, is to have a time after each worship service in which we shared experiences where we experienced God during the week. And that I think helped people to realize that in the midst of this, God is very real, very much alive, and very much present.
Thank you. And somebody wrote chat groups. You know, I mentioned my mother before. She never FaceTimed in her life until I bought her an iPhone during the pandemic so that she could see grandkids and cousins and nieces and nephews that are far away. And it's meant a lot to her to be able to see people who can't visit. And I've encouraged her to not FaceTime people too much, but when she is feeling lonely, that's another option other than just getting on the phone. Okay, so let's talk about referral. So in general, when we notice that someone has had significant signs or symptoms of stress or grief or trauma, again, duration is what is the measure here, more than 2 weeks ideally. We want to try to figure out sometimes where we can refer them for help. Symptoms of stress that begin to particularly affect their ability to, and I'm sure you've heard these terms before, live, laugh, and love. When someone is so stressed out, so traumatized, so grieved that they are not taking care of themselves, they're not taking care of those they're responsible for, and that can include just keeping their home clean or keeping a pet fed. It does not mean, just children or something like that. But those are people we want to make sure that are getting to appropriate care. Vulnerable populations, as always, include those who feel unheard, those with pre-existing mental health challenges, substance use and addiction, those living alone, those are socially and historically marginalized, and those who've experienced racism, racial inequity, phobias, and isms of all kinds. Reluctance and barriers that you're all familiar with, fear of provider bias, lack of cultural competence or religious competence on the part of a provider, loss of control, a perception of institutionalized care. People are often afraid that they're going to get institutionalized, particularly if they have a pre-existing diagnosed mental health illness, in particular those that require medication. Institutionalization is always a real fear. Diminishment and devaluation of one's role as a faith leader is a challenge for all of us. We've also had faith leaders in conflict with their congregations, governing boards who insist that faith leaders get back to face-to-face worship, even though the faith leader doesn't agree with that choice. There have been clergy terminated in the United States from their roles because they wouldn't get back to corporate worship. I can do this syndrome, the unwillingness or inability to acknowledge the limits that one has. Again, vulnerable communities, where are they in the disaster? Good reasons for them to be stressed as well as bad. How long have you had the symptoms? Is there anything in their answers or their behavior that concerns me? This again is a very difficult one when we're not seeing people person to person, that we're only seeing them virtually. And is this normal stress or acute stress is something we have to think through. These are some assessment questions that help us get past what we're not able to experience in person. How are you coping? And what do people believe is a sign of coping? I'm drinking more, I'm sleeping more, I'm showering less. What is not going well is one of the most important questions, because people often try to make things sound okay. I'm doing okay, thanks for asking. But what's not going well? Like, I don't want to necessarily end there, but starting there, somewhere in the middle, that's an important question. What are you missing? Is another one. And what do you need right now? What's your immediate need? And the ever inviting question of what can you get from me that you need? Presence, not presence, not presence with a T. Well, maybe the presence too, but what do you need from me? What can I give you? And have you passed a tipping point in your behavior that concerns you? Are you doing things that you are yourself are concerned about? Like, I'm not eating, or I can't stop setting the second place at the table, and it's been 6 months. And are you doing something that you haven't done before? This is always a very telling question. Sometimes a healthy response, and sometimes not. But what have you changed since you've experienced this grief or this separation or this anxiety? So as a rule, if you're going to refer someone, you want to tell that person you're concerned about them and why. What are your intentions? As a caregiver, your intentions are to help them, never to scare them, never to get them locked up, never the things that their anxieties feed off of. You can always make a commitment to someone that you're going to be a companion with them in the referral process, and you're never going to sort of abandon them to a treatment system that they're not comfortable with. The only time you rarely have an option is when their life is at risk, right? If they're suicidal, or if they're abusing substances or abusing people, then your choices become much less limited, much more limited, excuse me. Assure the person that you're going to continue to support them, care about them, love them, no matter what they choose, right? Our love as pastors, as imams, as rabbis, is unconditional love. Our love for that person does not change because they refuse to accept help. We can't be complicit in them not seeking help, but it doesn't mean they aren't loved. It doesn't mean we're going to stop looking in on them or stop caring for them. I want to blow through some of these resources quickly, and then we'll get into Q&A since our time is running out. We have a series of tip sheets at this link. You're going to get a copy of the PowerPoint, and we're going to provide you with a recording of the PowerPoint. These links are here for you to get access to these resources. These tip sheets are in English and Spanish. The Disaster Distress Helpline is always a great professional resource. People can access it through text or phone, and you can call the Disaster Distress Helpline with the person you're seeking help for. Stay on the line with them if that's something that they would like. And for young people, they can do the whole thing by texting if they're intimidated by getting on the phone with a live person. The National Suicide Prevention Lifeline is an important resource to always have at our fingertips, as well as the National Domestic Violence Hotline. As you're all familiar, there's been a significant increase in domestic violence, substance use and abuse, and suicidality during the pandemic. NAMI, National Alliance on Mental Health, also has a crisis text line that people can get help from. And SAMHSA, the National Administration for Substance Use and Mental Health, has this helpline as well. This is a free app that we have that you can download, that also, for those of you in chaplaincy settings, to give you information on how to help people of different faith traditions. You're going to get an evaluation at the end of this course. I hope you will fill it out so that you then get sent the slide deck. But at this time, I'm happy to answer any questions you have for the remaining time we have left. And we're going to turn off the recording so that you don't worry about questions being recorded and